next session, Beyond Compliance, Building Cultures of Quality. We now move forward to something that is essential, where the journey begins, not where it ends, compliance. This session invites us to reflect on a deeper question. How do we move from doing what is required to doing what is right, consistently, even when no one is watching? To guide us through this important conversation, we invite the chairperson, Dr. B K Rana, founding CEO of Quality and Accreditation Institute, a respected voice who has been instrumental in shaping quality frameworks across healthcare. Dr. B K Rana, please.
We now also welcome our distinguished speakers, Dr. Hanny Rono Sulistyo, Head of Foreign Affairs and Interinstitutional Affairs at the Indonesian Hospital Association, who will be speaking on digital health in Indonesia, enabling a culture of quality beyond compliance. Perspective that reminds us how technology, when thoughtfully used, can quietly but powerfully shift culture. Let's also welcome Dr. Rajini Ashok, Senior Director, Quality at Zulekha Health Group, UAE, who will take us through Raising the Bar, Transforming Accreditation into Excellence, a theme that challenges us to rethink accreditation not as a milestone, but as momentum. And finally, please welcome Dr. Rizwan Javed, Consultant in Apheresis and Cellular Therapy at Tata Medical Center, Kolkata, who will speak on FACT accreditation in India, challenges, opportunities, and global alignment. I now invite our experts to take on the session forward. Thank you.
Thank you very much. Good afternoon. Good afternoon, everyone. I think we are transitioning from good afternoon to good evening. So I think I can say very beyond good afternoon. And that's the topic is precisely beyond compliance, creating cultures of quality. And presence of people like you here in this hall, I think, is very positive for the panel. We were expecting that half of you will leave, but fortunately you stays and some new colleague joined. So thank you very much each one of you for joining this very exciting panel. We have been talking about quality a lot for so many years, but I think still in the debate you saw what was happening. So before we kick off the panel, I would like to give you a brief of what actually means about beyond compliance. Can I have my presentation, please? Sakshi. Thank you. So when we talk about compliance, compliance may be related to regulatory requirements, different regulations, law, which are applicable to healthcare organization. It can be related to accreditation organizations requirements when you choose to go for accreditation, or it can be related to your self-imposed. You can impose some of the regulations, some of the requirements, some of the criteria on yourself. So it can be against any of those compliances. So how you move beyond compliance and build a culture of quality, and I put 10 commandments over here for your consideration. And these are based on the experience which we have gained over the last 20 years in healthcare in India, and many of the parts of the world we are doing research on. Well, we should shift from checklist to mindset, and you have standards, you have tick boxes, and you keep doing it. But I think time has come that you have to move from that to changing your mindset that you have to do it, whether there is a checklist or not a checklist. Minimum to optimum, a minimum requirement set by regulations for licensing in healthcare facilities, towards moving toward the accreditation requirements, but you have to go beyond, which may be considered an excellence or best. Documentation to intent, SOPs, QSPs, policies, procedures, there are a lot of them. But what actually helps? The intent. Do you really have intent to implement those documentation which you very, very purposely prepare? From what I feel to what patient feel, and I think one of the sessions Dr. Venkatesh was talking about the same, what I feel as a patient when I enter a healthcare organization. Quality department to organization. This is one of the favorite thing I wanted to put here. Many of you are coming from the background of quality. So if something goes wrong, who is responsible? Quality manager, quality department. Do you agree with me? And when everything goes fine, now who takes the magic and credit? HOD, CEO, directors. Right, they have right to do, but I think we should start considering quality department as one of the major departments. And probably I would put next to CEOs, the quality directors and managers department or a cabin. So we have to move forward. Continuous to continuum. So continuously keep running without the break. But continuum means you have a stabilization process. You walk, you stabilize, you walk, and you like a staircase. Data collection to action. I think many of the accredited hospitals keep collecting data. Infection rates, SSI, PSI, PPI, so many things. But what actually do with that data? Do you act upon those data when you analyze? Do you really analyze them? Reactive to proactive, we react. Something goes wrong, we react. We don't look at what may go wrong in future. So I prefer to say we should try to see future. What may go wrong to my organization in next 1 year? Try to put them down. That's the proactive approach. Accreditation is the first step, not a destination. You get a beautiful certificate frame on your wall and you are happily thereafter. But you have to work towards moving forward to keep that certificate hanging on the wall. Blame culture to just culture. He did, she did. No, we did. Accept it, declare it, and move forward. So I think these are certain things we would like to, but how it will happen? How it can happen? It can't happen just like this. I talk about, you listen, no, it won't happen. Standards comes in. So standards play a very important role to support, and accreditation provide to facilitation of all these aspects, what I talk about. So standard plays an important role. Accreditation provides a framework, making use of a standard for building culture of quality and safety. So if you have these processes, who will do it? There should be an organization who should be doing it, and that's why the role of accreditation body comes in. You talk about NAPI, JCI. Briefly, QAI, Quality and Accreditation Institute, is an internationally recognized accreditation body, providing 24 accreditation program as I speak. You may not read it, but we have pre-hospital, hospital and post-hospital care accreditation standard. I'm very happy to see Rizwan coming here talking about fact, JC standards. We have developed SCT, hematopoietic cell transplantation or bone marrow transplant center accreditation program, first in India and second in the world after fact JCE. So we have very unique programs which support organizations even beyond accreditation as a hospital for a specialized care. We are recognized by CGHS for empanelment as equivalent to NABH for all incentives which we like to go for. And you can see the latest MOA of CGHS mentioning NABH, JCI, NHSRC and QAI in their own official document to give you the confidence. Karnataka Private Establishment Act recently amended the act that if you are accredited by any of these three agencies, NABH and QAI, would not be inspected for registration or re-registration, you will be granted in 10 days without any inspection. So that's the power of standard and accreditation. We are present in 15 countries as I speak. So what is important for us beyond compliance is get it right, make it safe. You can't choose to decide, you have to choose what is best for the patient and patient safety. So you need patients' involvement, you need healthcare workers, all of you involvement, you need managers, CEOs and directors to be involved, policy makers, obviously, the government, the regulators, and civil society and partners which help organizations to create culture of quality. So I think this is what the context is for three of the panelists we have here today. We have Rizwan, we have Rajini, and we have my colleague Jano from Indonesia. They will be talking about three different things, how they move towards excellence, even beyond compliance. So I think I just finished my presentation. I would like to invite the first speaker, Dr. Rani from Indonesia, talking about digital health in Indonesia beyond compliance. Over to you, Ronnie.
Professors, dear ladies, dear gentlemen, I am from Indonesia, from CARS, and I'm from ASQA, the president-elect of ASQA, and I was sent here to talk a little bit about digital health in Indonesia. This is the principles of the health program in Indonesia. The vision is from the president, and the vision from the vision and the mission from the MOH is about first primary healthcare, secondary healthcare. Health resilience is drug and laboratory radiology. The fourth is universal coverage. The fifth is human resource, and the sixth one is hospital technology. It's IT. So this is the dream of the Indonesian government, just to make a program about all the ages. The first one, what the MOH, I just want to tell you that our minister is a banker. He's not a doctor. He's a banker. He's an engineer. So what he's doing after COVID is making the IT. So he pushed all the hospital. They have to use e-medical record or you close. So late 24, you must finish or you close. So everybody is fighting with that, and luckily there's one firma who give it free of charge. So maybe 2,000 hospitals use it. So it's about 400 plus health system is there in Indonesia, and about it's saving cost for paper. This is the dream of him and the dream of us, to have one data of health. So this is one health. Satu sehat is one health. So everything is going into that one health. So above you can see this is about pharmacy, about ICD-10, ICD-9 is for the hospital universal coverage, and then mother care, and then facility of the bed, also SNOMED for terminology and diagnosis, and drug, everything is here. Also we have programs, Satu Sehat Mobile, so the people can use, they can open their medical record, but only a small part of the medical record is already there, and one data, Satu Sehat data for all Indonesian, and electronic medical record. And for accreditation also, we must put through them, and registration for the doctors, nurses is going through this Satu Sehat also. So about 38,000 facilities joined together, and 61 million patients joined the Satu Sehat already. 1.8 million doctors get a lifetime registration. 56 artificial dashboard. So you can see here, this is the program, and in the middle is the watch up. So because Indonesia watch up is very popular, so the patient can watch up everything. This is the blue, the green one is the users, and the red one is the not yet users. So the first one is hospitals, it's nearly 92%. Puskesmas, first primary healthcare, 90%. Clinics, laboratory, and doctors practice, private practice is very the lowest. This is the data. You can get the result also from what's in the data already. And then this is the 10 most the disease, priority disease. See, mostly is heart disease, diabetes, maternal, cancer, tuberculosis. We are number 2, tuberculosis, but still not very good. So it's going up. This is free health check. So all the people in Indonesia, 300 million people, get a free of charge health check during their birthday. So if they have birthday, they get free check. So everything is going here. So it's if you go universal coverage, you don't have to queue or something. Just put the number of your license. This is for human resource. This is if you want to queue and you want to know where this hospital need everything, need nurses, everything is here. So it's one data, so everybody got the data. Yeah, this is for the people. So the people can. It's about stunting. So it's going with the CAHOCON. So people can check, monitor supplement feeding, and then everything is here. This is immunization registered, about 21 million people more. This is the dashboard to see how many the immunization in Indonesia and in the region. This is non-communicable disease screening. This is, you get from, if you got screened, you will know a little bit about you. This is the data also. This is digitalization for children under 5 years here, and we can see this is the good one and the bad one. This is the ultrasound. Ultrasound is going to the primary health care, so they can put it here and they can ask to the doctor or to the OBGYN whether it's good or not, something. It's in the and then this is the president priority about food. So they give free food for the school children. This is our minister, he's the banker, and he do many things about IT. I think that's all. Thank you very much.
Thank you, Dr. Hanny. Thank you very much for the presentation. Moving on to the next, Dr. Rajini. She's going to talk about raising the bar beyond accreditations towards excellence. Over to you, Dr. Next. So,
good evening, ladies and gentlemen. Greetings from Zulekha Hospital, Sharjah and Dubai and the United Arab Emirates. Our both hospitals have been accredited over several years with the Joint Commission International, and our laboratories have the College of American Pathology accreditation. We have been using these accreditations as frameworks to win several certificates of excellence and awards over the years. Often we think that once we have accreditation, we have attained excellence. But the actual answer is, have we? No. Why is it so? This is because while accreditation meets the standards, excellence challenges us further and raises the bar. Excellence makes us outstanding.
Friends, today I invite you over the next few minutes to join me as I take you through the journey that Zulekha Hospitals shared from accreditation to excellence. Like any other organization, when we embarked on the accreditation journey, the major challenge that we faced was the staff misconceptions. The staffs were anxious, fear of being inspected by outsiders, having opinions of outsiders thrust on them. Probably they would be blamed if there were non-compliances. In the middle of their work, they would find other time-consuming work which would add to their anxiety and stress. And after all, it was not their job. It was a job of the quality department, and why should they be doing it? With the starting of the accreditation journey, a lot of these misconceptions started getting squashed. They realized that the tracer methodology that was used was converting the patient's journey into measurable standards. It was no longer just an inspection. It was not an exhausting and time-consuming activity because with time, a lot of variations were deleted, a lot of touch points were out, and system efficiency improved, and it became more interactive. There was no one who was coming and thrusting our opinion on any other medical provider. The Joint Commission International, the surveyors, would come in and bring in good practices from across the globe and suggest it to us if we would want to include it as if it is applicable to our infrastructure and our scope of practice. And much to our pride and happiness was the fact that they took many of our good practices across the globe. This was in fact very motivating to our team. Was this a task only of the quality department? Initially, that is what it was considered to be. We heard some speakers also earlier mention this concept that is there in an organization-wide concern. With time, we started taking inputs from the staff in making our policies. The quality department became a facilitator department, and policy making now became an organization activity, increasing the accountability of staff and making it more interactive and more sustainable. Were staff forced to change their ways of work? No. They realized that when positive outcomes come with using evidence-based practice and standardization of practice, the logic of using evidence-based practice was realized and a lot of variations in practice declined. Accreditation is a strong bridge that takes administration policies to the bedside. A palpable change that was seen was a change in the culture. What was considered as non-compliance or errors were now marked as areas for improvement, the birthhouses of many processes. This was a leadership-driven movement. This improved the reporting and transparency in the organization. The staff started developing your own mistake culture. A fair and just culture was born in the organization. We all have in our organization checklists. We tick checklists at different times of our jobs to see if an activity is done. But with accreditation, this concept of ticking the checklist changed. It was not to see if it was done, but it was to see how it was done. These checklists were used now as performance tools. The mindset changed. It changed from ticking the box to fixing the problems and fixing the trends. And then concept of delivering safe care every day became a reality. A very important activity that we learned from in our accreditation to excellence journey is how data was to be reviewed. Staff, when they compile data, were often bogged down with concerns that this is just unnecessary paperwork and unnecessary numbers that are being compiled. When we looked into the data, we were taught how to look into the data during the accreditation to excellence journey. that data is not what it actually looks like. It needs to be reviewed. But only when you review it, you identify your areas for improvement. Actually, your KPIs and your indicators of data analysis should be reviewed and as like a vitals monitor, where you should identify the spot risks of your organization. We had a very interesting session on whether CAPA is required or it's an eyewash. I'm not part of that debate, but a CAPA should be done with stakeholders and corrective actions should be implemented. Dashboards should be reviewed to ensure that if you are sustained, then retire that particular KPI. Very often when we consistently reach 100%, we have a tendency to feel secure and relaxed. But this may not be a true sign of safety. It could be an alert. It could be that is now that we have made our thinking optional. We probably had not been collecting data that was meaningful, or it is now time to relook the data. Often, as organizations, we collect data, and most of our organizations do not face challenge of data problem, but what we face is a problem of decision problem. And this is primarily because we do not review our data. This was a great lesson that we learned in our Accreditation to Excellence journey. That being said, I'm sure there are many organizations in this audience who have probably attained many excellence certificates and awards without accreditation. My congratulations to all of you. It's a great job. But it's truly a masterpiece without a signature, an act of brilliance, but which is not publicly acknowledged. With time, you face the risk of having variances in your practice and also losing out on some privileges like the international medical tourism or affiliation and partnerships. I conclude my talk. Excellence redefines accreditation. Accreditation should never be the end point, but should be our demand for excellence. While accreditation is the foundation, excellence should be our goal. I feel honored and privileged to address you all today, and thank you all for your kind attention.
Thank you, Dr. Rajini. Thank you so much. You were well in time. Thank you so much. Really appreciate it. Moving on to the next speaker, Dr. Rizwan. He is going to talk about FACT accreditation for bone marrow transplant centers. Over to you, Dr. Rizwan. Thank you.
Hello. Yeah. Good evening, everybody. I'm trained in apheresis and cell therapy, but I also serve as a fact inspector. Now, for those who are wondering what it is all about, it's about Foundation for Accreditation of Cellular Therapy, which is based in the US. And its counterpart happens to be JC in Europe. Both the bodies together form global standards for hematopoietic stem cell transplant, in simple words, bone marrow transplants and cell therapy. Now, what I'm here to do today, in 7 minutes, I'm supposed to share my journey, as we are the first center and one of the two in the country, or rather South Asia, at Tata Medical, to be fact accredited for our transplant program. But I think in the paucity of time and the best interest of the audience, I would do away with chest thumping and focus on how the challenges that exist before us, because we have in our audience a very beautiful audience comprising of administrators, doctors, nurses, and quality professionals. So to this mixed audience, I would like to share as to how we overcome challenges to set ourselves with opportunities that could align us globally, as we talk more often about Vishwaguru these days. I have no personal vested interest apart from my current employment at the backdrop of the hospital that you can see, which is Tata Medical Center. And if I have to introduce with the landscape of bone marrow transplant cellular therapy in India, then a quick snapshot would tell you that in India, we roughly have 120,000 cases of blood cancers diagnosed every year, out of which so far 27,000 transplants have been done till date, ever since the first transplant happened in 1983. And out of this number, 80% of the transplant happened in the last 1 decade. Now this is significant because as we grow rapidly and do 3,000 transplants every year, increasing the number of transplant centers for over 114 that we see, it is important to note that as a growing country with a vast need, we have an unequal rapid expansion, and that's costing the quality in big way. Infrastructure is unequal, it is poor at some places, sparse trained workforce, because for a critical specialty as transplant, it is not as quick as admitting a patient into a ward and giving chemotherapy. You also have to set up facilities for collection, processing, and that requires, in most of the centers today in India, are outsourced because they involve more investment in terms of time, manpower, and money. Now, how does it impact us? If we grow on unequal scales, having this robust expansion without getting in quality, it leads to inconsistency in service and leads to a poor global reputation and credibility. So out of these 104 which are there, if a couple of them don't do well, it brings a bad name to all of us. And that's why, to match up with the scale, quality is imperative to improve. Now, I personally would like to suggest, in my 2 cents to the discussion on CAHA, that there is no final destination to quality. It is a self-improvement exercise, and it is no less than a project. A project where we just try to self-assess ourselves and see if we are better than what we were last year. And for that, it's important that we get our systems in place to be safe, improve the experience of care for our patients, and make sure that our therapies are effective. And all this in real time, done in a systematic approach to assess it. Now, the person who first ever introduced quality in healthcare was the American Lebanese physician, Dr. B K Rana. And to go by his model, there were just 3 spots, which were structure, process, and the outcomes. Now, we all focus on the structure, which comprises of the infrastructure, but it is equally important to make sure that we have our interactions, the processes right in place, written, standardized, and formal. And most importantly, assess the outcome. Having treated the patient and losing them to follow-ups would be a tragedy, because having the morbidity, mortality data of our patients is equally important. And why do we need this? And assessing all these fundamental pillars of quality are accreditation. I cannot overemphasize why accreditation is important, which is done by third parties, independent. In simple words, it's a peer review exercise which does not only cover the transplant program, but also the collection and the processing, making sure even the donor goes home well, not just the patient. And then the only 2 bodies in the world is FACT and JC, which have, for these niche specialty areas called hematopoietic stem cell transplant. Now, making a biryani is not easy. You need to have it in the right ingredients, in the right proportions. And that's what the different structure in quality is. Now, I cannot overemphasize to quality professionals here that apart from infrastructure and personnel, quality management systems, SOPs, we need to be also regulatory compliant with consent forms and labeling our products, because in the world that we live, where products fly in 24 hours from one continent to the other, depending upon where the donor has been matched, it's important we label them not with handwriting, but a standardized labeling system. And that's how important it is. Now, when we started this journey in Tata Medical Center, Calcutta, the program was already in its 10th year. So we already had the infrastructure in place. So what were we about to do? All that we were set out to do was make sure that we have a work plan or a flow chart of our workflow to ensure that the flow is appropriate. Environment, even the air-conditioned hospitals have air handling units. But it's important to maintain those cleaning records and actually in real time check for the temperature and humidity. Now, having said that, personnel, we know the organograms have to be set in and who interacts with whom. have to be clearly sorted without any confusion. And apart from that, for almost every staff, qualification, job description, privileging, and ensuring they are healthy in a niche area like transplant is extremely crucial. Managing, like all other places, a quality management system. So for all hospital administrators who would think of extra investment when you get in more people to be recruited, all that we did was invest 2 hours extra from all our present positions to work on a quality management program, make our own SOPs and policies, because the best part about FACT accreditation was that it wasn't prescriptive. So it allowed you to make your own SOP without copy-pasting Western SOPs. And as long as you have rationale for what you're doing and scientific understanding, it is sufficient. And that is exactly what we went around doing. The other important crucial aspect to have a standardized WHO recognized ISPT 128 labeling system for all the products that we manufacture. Because eventually these are the products which will be given to patients and has a unique donor identification number so it can be traced. We categorize all of them under the umbrella of quality and all the processes which I may not be able to elaborate due to paucity of time. But what I would like to make sure that at the end of it, what the administrators gain out of this exercise. You get an annual report which tells you how effective your program is, a cell therapy program. With the advent of CAR-T products and cell and gene therapy growing even further, you would like to know how many patients have benefited, who were the recipients, what was the diversity of challenges you faced, and how good your patients did. If it was not for anybody else, it is for ourselves. Because when we have global standards at home, it only ensures that we are confident to get ourselves treated, God forbid if we need it, or get our loved ones to the nearest center possible. And when we do not create those centers in our own country, we go around shopping hospitals in other continents, which will be a tragedy in the long run. And having an effective audit which comprises of all the factors, putting in the numbers and the 5 whys and fixing your processes is equally important. In the whole efforts, we also devised quality indicators which were very objective assessments of our work and were not taken out just by Western data. And probably this would set up Indian benchmarks for us as Indian centers because our cohort of patients are very, very different from any other. To briefly mention about the accreditation process, which comprises of the initial accreditation, it comprises of a detailed compliance application. Now, if nothing else, they are a self-assessment exercise, and any center interested could join the India Working Group of FACT, which meets every month online, and once you are ready, you could finish this process within a year. What it empowers us today is in the last 1 year, we have had MOUs with registry, with the growing Indian diaspora, collecting products from unrelated donors in our region and sending them across the world as far as to Chicago and New Jersey and Boston. Contributing to international data which is based in Wisconsin so that we know our patients, how they fare internationally and put ourselves on the global map. Having mentioned the benefits, it's important to start with the team building, and these challenges could be overcome with the robust growth that we see. I finally acknowledge with the grandfather of transplant, who was my mentor, and the visionary, Dr. Chandi, who actually embarked on this journey during 6 years ago when we actually started the efforts. Thanks to the entire team, because you take a village to transplant. And if not for anything else, I think what it serves is the smile on our patient's face. That's a 2-year-old child and a cerebral palsy donor whom we collected at our center. It's the joy of making sure and the confidence that you're able to give care to those which is global standards, and the nearest part is what gives immense satisfaction to all of us. I'm happy to help centers who would like to embark on a similar journey. Feel free to drop in a text and we'll be happy to share more. Thank you so much.
Thank you, Rajwan. Thank you so much. Thank you so much. And I've been impressed like anything. I can't explain that you need to close the session because they're waiting for the next session. So thanks, Hanny. Thanks, Dr. Rajni. Thanks, Rajwan. and you may interact with them as we break the session, and you can have questions and clarifications. So thank you each one of you for your wonderful, I'm so sorry, can't take questions, so exciting topics, but I have limitations. So thank you. With this, I close the session. Thank you, everyone. Over to you.
Good for you.